Hey everyone, and welcome. Today we're going to tackle two of the biggest questions in oncology. First, how does a tumor in one place, say your colon, end up causing problems somewhere totally different, like your lungs? And second, what's actually happening inside the cell's DNA to make all this chaos happen? We're going to build a super solid foundation for you to really get a handle on metastasis and the genetic drivers of cancer. So let's jump right in.
All right, let's kick things off with a classic clinical scenario, the kind of thing that really makes you connect the dots. So picture this, a patient who you know has colon cancer comes into the clinic, but they're not complaining about their stomach, they're complaining about being short of breath. Now, at first, that sounds kind of weird, right? A problem in the gut causing a problem in the lungs? How on earth is that possible? Well, the answer is the absolute core of what we're talking about today, metastasis.
So here's our game plan. First, we'll track the journey of metastasis. Then we're going to dive deep into the genetics, looking at oncogenes, our stuck accelerators, and tumor suppressors, the failed brakes. After that, we'll hit the high-yield genes you just have to know, and then we'll tie it all together with a clinical summary.
Okay, let's solve our puzzle. That link between the colon cancer and the shortness of breath, it's all about metastasis. This is the process where cancer cells from the main or primary tumor break off, hop into the bloodstream or lymphatic system, and basically go on a road trip to set up shop in a new organ. In our patient's case, they traveled from the colon to the lungs. It really is a journey, and a pretty dangerous one.
Now, these cancer cells aren't just wandering around aimlessly. They have preferred highways, and there's a really good rule of thumb here. Carcinomas, which are cancers from epithelial tissue, usually spread through the lymphatic system. On the other hand, sarcomas, which come from connective tissue, tend to spread through the blood. We call that hematogenous spread. And the best way to remember this is with a super simple mnemonic. CLASH. Carcinomas, lymphatics, sarcomas, hematogenously. CLASH. Got it?
Okay, so you know how it is in medicine. We learn the rules, and then we learn the exceptions. And these exceptions are so high yield for exams, you guys. So while most carcinomas take the lymphatic route, there are four major ones that break the rule and prefer to travel through the blood, just like sarcomas. You've got to know these four: follicular thyroid carcinoma, choriocarcinoma, renal cell carcinoma, and hepatocellular carcinoma. Seriously, make a flashcard of these right now. They love to ask about these.
And this table shows you where these traveling cells often end up. You can see some really clear patterns, like see how bone is a super common spot for prostate and breast cancer to land? And look at the liver. It's a top destination for colon cancer. That makes total sense, right? The portal vein drains blood straight from the colon to the liver. And now look at the lung row. This is it. This is the answer to our puzzle. The lungs are a common destination for metastases from, you guessed it, colon and breast cancer. And that's exactly why our patient was short of breath.
So we've talked about how cancer spreads. But now, let's get to the why. What is so fundamentally broken in these cells that makes them do this? The answer is in their DNA. We're going to start with a group of genes called oncogenes, and the best way to think of these? They're like the accelerator pedal in a car.
Let's be really clear on this definition. In all of our normal, healthy cells, we have genes called proto-oncogenes. Their job is to tell the cell when to grow and divide, but in a very controlled way. They're like the managers of cell growth. An oncogene is what happens when one of these proto-oncogenes gets mutated. It's what we call a gain-of-function mutation. The gene is basically stuck in the on position, screaming, go, 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 all the time. And here's the kicker. Because it's a gain-of-function, you only need to damage one of the two copies, or alleles, of the gene to cause a huge problem.
This car analogy really makes it stick. A proto-oncogene is your normal gas pedal. You press it when you need to go, you let up when you need to slow down. It's controlled. But that gain-of-function mutation, that's like a brick getting jammed on the pedal. Now the accelerator is stuck to the floor, and the cell just goes into this relentless, out-of-control growth.
Of course, every car with a gas pedal needs a good set of brakes, and our cells have them too. So if oncogenes are the accelerator, tumor suppressor genes are the brakes. Their whole job is to slow things down, repair any DNA mistakes, and tell a cell when it's time to die. That process is called apoptosis. You can really think of them as the guardians of the cell.
Now, the key concept for tumor suppressors is totally different from oncogenes. It's called Knudson's two-hit hypothesis. Remember, for an oncogene, just one bad allele was enough. But for a tumor suppressor, you have to knock out the function of both alleles. This is a loss-of-function mutation. So the first hit takes out one copy, but the cell is usually okay because the other copy can still do the job. It's only when you get that second hit and lose your backup that the brakes fail completely.
Let's go back to our car. A normal cell has two sets of brakes, one from each allele. The first hit is like one of your brake lines being cut. Yeah, it's not great, but you can probably still stop the car. You're compromised, but you're not crashing.
The second hit is when that other brake line gets cut. Now you've got no brakes at all, and the car, or the cell, is speeding towards disaster.
Okay, let's get specific. We've got the concepts down, so now let's meet some of the key players, the actual genes that you will absolutely see on your exams and in your future clinical practice.
When we're talking oncogenes, these are the heavy hitters. You'll see them everywhere. For instance, EGFR mutations are classic for lung adenocarcinoma. HER2 is a huge deal in treating certain breast and gastric cancers. And that BCR-ABL fusion gene, that's the one that basically defines chronic myeloid leukemia, or CML. These aren't just names to memorize. These are the actual molecular targets for many of our modern life-saving cancer drugs.
And for the tumor suppressors, TP53 is the undisputed celebrity. It's called the guardian of the genome, and for good reason. It's mutated in over half of all human cancers. It's a huge deal. Then you have BRCA1 and BRCA2, which I'm sure you've heard of. Mutations here are behind many cases of hereditary breast and ovarian cancer. And finally, APC is the key gene to know for colorectal cancer, especially in a condition called familial adenomatous polyposis.
Awesome work, everyone. We've gone all the way from a clinical case down to the molecular level. So now let's put it all together one last time to make sure these concepts are locked in for good.
This table right here is your ultimate cheat sheet. Let's just run through it. For oncogenes, the analogy is the stuck accelerator. Their function is to promote cell growth. The mutation type is a gain of function, and you only need one bad allele. For tumor suppressor genes, the analogy is failed brakes. Their job is to inhibit cell growth. The mutation type is a loss of function, and you need to knock out 2 alleles. Seriously, if you walk away with one thing today, let it be this table. So why do we care so much about all this? Well, because this knowledge is completely changing how we treat cancer. When we can identify a specific mutation, like HER2 in breast cancer, or that BCR-ABL fusion in CML, we can use what are called targeted therapies. These are drugs specifically designed to attack that one molecular weakness. This is the future. It's personalized medicine. And understanding these basic principles is the first step on that road. I really hope this helped clear things up, and I'll see you in the next explainer.